So yeah, never upset the hygienists. But before we move on to pharyngometer, let's see how well you learned last month. Which side is left and which side is right? Which line? What color?
Oh gosh, now you're putting me on the spot. So left side is the purple one.
Correct. Very good.
And then the right side is the yellow one.
Right. And so that first blue line is what marker?
The anterior turbinate.
The blue line though. The zero.
Blue.
At zero. That's where the tip touches the nose.
So, okay. Okay.
All right. And then that first marker is going to be nasal valve. And if the average is the big line that you see in the middle of that diamond shape, am I above or below average?
The first line in the first diamond shape that I see.
So they're towards the upper limit of what statistic norms were considered by Atul Malhotra. So I'm above average at nasal valve.
I see that.
And if we move to the second marker, that was the anterior limit of your inferior turbinate. Do you see how the right side, the amber color line, just drops below average there?
Yep.
So I'm a little bit smaller right now on that right side and a little bit bigger than average on the left side.
Okay.
And then as we get to the third marker at 6 centimeters, I'm right on average on the left, and I'm still a little bit below average on the right.
This one we're talking about, right? Are you able to see my cursor just so everybody knows what it is we're talking about?
So
yeah, right, okay, I can see yours. Perfect.
This is nasal valve, and this is anterior inferior turbinate, and this is posterior limit of the inferior turbinate.
Perfect.
And there's also nasal cycling that happens. So if we came back and did the same measurement on the same patient, and it was after the nasal cycling had changed from left to right, because we're designed to take a little break from one side to the next, it may alter. And it doesn't mean that you did anything wrong. It doesn't mean that it's inaccurate. It just means that that's what the measurement was at that particular time in that particular position, with the patient doing whatever they were doing. So if they're breathing, those will be hard to repeat. If they're not breathing, it should be fairly stable and give you a good accurate measurement. What else can I talk about here? Do you have any other questions on the rhinometry?
No, I think the rhinometry is pretty straightforward for the most part. I'm glad we're able to share this graph and everything with everybody so they know exactly what it is.
I think clinically too is, you can verify what you see on the graph with what you can hear in the treatment room. So I would have them place the finger over the left side, close off that nostril, have them take a breath in, then do the other side. So if they were spread apart more, where one was significantly smaller than the other, maybe like, how when you get the stuffy nose and one side seems to plug up and the other one you can breathe through, and then like you wake up later on and it's flipped over and it's completely different, and maybe like you slept on that side, or you wake up and both sides are completely closed off and you can't get anything, you'll hear the sounds.
Right.
Also, I think if we have a small nasal valve, I'll have them do it. Like my nasal valve's above average, but I have a very collapsible nasal valve. Like I actually wear a dilating strip.
Dilator, yeah. And that's something we look at nasal valve collapse during our evaluation. Another trick that we do that Chris and I teach in our myo class is having somebody grab their phone, hold their phone under their nose so the screen is dark, and breathing on it to watch how you fog it up if one side's bigger than the other, or so forth, if they're even, whatever the case may be.
I love it. I love it. That's a really good, useful tool right there. Also, I think I had another thought here, and now it's kind of escaped my mind, but it'll come back to me when we move on, I'm sure. But rhinometry, oh, I got it. I love it. This is getting older, stinks, man. But I think a lot of dentists are uncomfortable examining noses. It's not the oral environment. It's not the oral cavity. And a lot of dentists make oral appliances without looking at the nose. Now, I don't know if the orthodontists have it in there. If they're not an airway orthodontist, they may not look at the nose either, because they're taught to straighten teeth. And they do a good job of it. But, straight teeth that don't stay where they put them, to me, was a telltale sign. So it was like, I could never rationally figure out with what I learned in dental school, why so many people relapse. And why does crowding come back? Like, we just spent all this time and money and energy to put them where aesthetically they look good and they fit together great. But if we don't hold them there, they don't stay there. Like, I always think of the line from Jurassic Park, the very first one. So this is probably like older movie than you are, but shows my age, I guess. But if it's not right, nature finds a way.
Yeah.
I love that line, because it's exactly what happens. If your dentistry is breaking down prematurely, and that's what was so nice about being a young dentist, is like all your work was successful because you didn't have to follow it. Whatever you did your first year, your first patient, you only had to see it for the next 2 years, and then it was done. But when you get into practice and you're 5, 10, 15, 20, 25, 30 years into practice or more, you start to look at dentistry differently, because you're like, well, who did that? And then the patient says, well, you did, doc. And you kind of got to, oh, hey, must have had a bad day that day. Or wow, what have you been doing to it? I know it didn't look that way when I did it. And so there was all these like signs and symptoms that kept coming up, and I couldn't explain them. And that's really, I think, what ultimately led me into the airway path, even though a lot of things in science are stumbled upon. I think I stumbled into it. And over time and making mistakes, honestly, were important lessons. And that's why I get to teach now. So it's like, do as I say, not as I did.
Learn from your mistakes.
Exactly. So that's it for rhinometry. It's a quick assessment. It gives us great information. If there was a problem, the line would tank off and drop. So once the sound hits something that it can't get past, it reflects back to the microphones that are in the instrumentation. And we'll see that line just drop to 0 because it couldn't get past it. The other analogy that I'll use when teaching is, if you think of a bat that's flying in a dark cave, they can't see all the stalactites that are hanging from the ceiling or the walls of the cave, but they never hit anything. So they're doing a very similar process of sending out echoes, and their brain is processing that information so they don't run into stuff. All right, so let's see. Let's close rhinometry. I want to close the application. I got to move my screen. There we go. Wrong X. I'm not going to assign a patient. Now we'll go to pharyngometer. You'll hear a knocking sound. That's the calibration. And for those that can't see the screen, what pharyngometry is basically a mouthpiece, like a snorkel would use. And for this test, we're going to hold the instrument, and I should probably unblur my background. So let's see. You get to see my clock and what time it is. There we go. All right. So there we go. We're going to put this in the mouth. Teeth come together, upper arch to lower arch. Tongue goes underneath. That's the tongue depressor, so the sound can get past the tongue. Now that totally rocks your world, I understand, because it's far from the spot, but we need to be able to get the sound past it. So again, this is just for the measuring.
Yep.
I'm going to pinch my nose so the echoes don't come out my nose, and they're going to go, we're going to see the same thing, distance and then size. So first one's going to be, I probably need to take this off my screen. First one's going to be breathing normal, and I'm going to stop it halfway through my exhale. Perfect. Now you can tell by the line being off the top of the graph here, my airway is ginormous. And so on a CBCT volume, if you did the pretty picture that shows the green, the yellow, and the red for the airway, what would you tell this patient? Your airway's big, not a problem, right? So let me change the graph paper here to where you can see I usually have to go up to like 15 square centimeters.
Oh, wow.
So there we go. Now we can see the top of the mountain. What is left of the blue line is the oral cavity. So there's a 0 out here. That's where the tip goes into the mouth, and it just goes right past the front teeth. And then you'll see a rise for the palatal vault, and then it comes back down as it hits the junction of the oral pharynx. So I had tonsils removed. This is why I don't have my constriction at oropharyngeal junction. We call it OPJ. If you look in my mouth, I'm a Mallampati 1. And I was doing, I was moderating the Academy of Laser Dentistry sleep track panel, I think 2 weeks ago now. And the doctor that was presenting said he's never seen a Mallampati 1 that has obstructive sleep apnea. And so I kind of had to raise my hand and say, well, if I come to your practice, I'll show you, because that's me. You know, I'm the patient that, unless you walked in the door saying, you know, I snore, would be totally missed. So that's baseline airway. You know, my average volume is 100 cubic centimeters. My average when I'm breathing is 8.4 square centimeters, and my minimum is 5.4 square centimeters. So just to give it some norms, I always say sleep can be as easy as 3, 2, 1. The average airway, men and women, is right around 3 square centimeters. So 3.2 for men, 2.8 for women. When a minimum in a collapse goes below 2, it's technically 1.86, but let's just round up. This was Atul Malhotra, again, his data. When a minimum collapse goes below 1.86, I just call it 2, the odds of getting a diagnosis from a sleep study are significantly high for a moderate to severe diagnosis. Now, echovision is not diagnostic. It's just a tool that we use that suggests, and it shows the patient why you're having this conversation with them. Because honestly, 90% of them are unaware. Most of them came to your practice not for airway. You know, if you're a normal dentist, if you're an airway dentist, then yeah, they're there for it. And that comes back to, like, don't get into the rabbit hole of having the conversation in hygiene when the patient's not ready to talk about it, or because they won't hear anything. You're just going to waste your words.
Absolutely.
So set them up to come back for an airway consultation. Do what they're there to do that day, and then plant the seed. You know, a lot of this is farming. It's planting the seed. It's connecting the dots. It's getting the light bulb to turn on above their head to where they own their problem. So you can't sell them anything. You know, you can't give them a treatment plan until they've taken ownership that, hey, this is a problem. This is why I'm tired. This is why my bed partner's sleeping down the hall. This is why I'm so moody or anxious. And a lot of these patients are hidden. Like, they're not the stereotypical old fat guy that, you know, the bang side of the stop bang will pick up. And really just have a 3-question screening while you're taking your blood pressure on the patient. You know, are you on blood pressure medications? You can pull those people out before you even seat them in the chair. Normally, you've got the health history in front of you. Are they over 50? Do you struggle to get the bib clip around and get the napkin chain, you know, connected from one side to the next? That's, you know, big neck. Are they overweight? You know, are they spilling over the dental chairs? Dental chairs have gotten bigger over time, and we still have people that are overspilling it. So, you know, as soon as you get to 3 of those common signs and symptoms, you got to start thinking, I need more information to know if there's an airway problem.
Right.
But in my case, baseline would show no problem. I'll go to the next step is a collapse. So same thing, it's going to normal breathing. And then once I hear the tone, which happens after about 10 or 12 pings, 5-7 seconds in, that's when it has an average line. And so the instruction to the patient is, on your next breath, slowly, silently, and completely blow off all of that air and just raise your pinky or raise the hand that you're not pinching your nose with to signal me to stop the test. When you hear the knocking sound stop, then resume your breathing, because you want them, when you take this out of their mouth, to kind of have that gasp. You know, I know we don't like to have the gasp, but that's what the test should be doing, because that's what's happening when they're not in control of their breathing pattern, when they're asleep. And so here is my collapse test, and I think you'll see it really evidently. Always makes me cough. And that's kind of what you want. If your patient doesn't struggle, like afterwards, they're protecting their airway, which is what people that have compromised airways do. So think of the patient that, you know, You just know when you see them on the schedule that you're going to need extra time because they stop you every 5 minutes. They've got to hold the suction the whole appointment. You put the x-ray sensor in the mouth and they kick it out of the place. The tongue's in the way no matter where you're working in the mouth. They just really don't want you in their oral environment because it's a threatening feeling. If you're lying back in the chair and you've got some person that's trying to do work on you, they struggle there. So if I go back to baseline and I superimpose the collapse, do you see the separation between the lines? The red one is way down at the bottom.
Yeah,
the
definitely.
green one's way up at the top. And like, how would we get that information in a cone beam? You'd have to have them blow off that whole breath and then start the machine and run it around their head for however many seconds it takes to take a scan. And you just can't. You can't be that much out of breath for the duration of the cone beam scan. Now, there's other ways to use radiographs to assess airway. There's cephalometric norms and angles and distances between different markers. And those are all great methods and ways to do it. But again, it requires radiation. It requires taking the image. And then how often are you going to do that? This is simple. This is something that, if the patient was unaware that they had an airway problem, he's like, well, look, when you're breathing, that's the green line. Look how big that is. Right. And then the red line was like when you were almost out of air. You weren't even out of air yet, but you were almost out of air. And your airway went down to 1.7 square centimeters. And what did I just say 5 minutes ago? Below 1.86?
1.8, yeah.
Below 1.86, your diagnosis is going to be moderate or severe. And so this led me to doing a sleep study at home. And it showed that I have moderate sleep apnea. So I had an AHI, I think, of 18 the first time I did it. Now I was 72 pounds heavier then, and I need to retest myself that I've lost the weight because, my girlfriend says you don't snore no more. Like, it doesn't matter if you're on your back, your side, you don't move. Like, you don't even wake up. And that was what led me to thinking I might have a problem is, I get close to 50 and all of a sudden it's 5 or 6 times to get up and use the restroom during sleep. And, I wear an Oura ring, I wear a Garmin. So I've got all the techie devices. I'm just the super nerd when it comes to airway and dentistry.
Aren't we all?
And they're not on the level of an actual sleep apnea test, but I think it's a good coachable device. I think it gives us good information to know what are our habits that are influencing our sleep. Do we have a routine bedtime? Are we going to bed at the same time getting up? Do we have caffeine too late in the day? Maybe we shouldn't have had that extra drink that we put on, or the late meal, or exercise in the evening. All the things that we think of. Dark room, heavy blanket. There's some debate on blue light and screen time going on. These are all things that we're aware of. To me, it's fascinating. I just think it's fascinating.
I just think it's such an easy tool to begin implementing, to have something to be able to back what it is that you're saying to the patient, especially for the patients where they're hearing for the first time, that they have some kind of airway issue going on. And, to be able, like you said, to incorporate it via the hygienist, the assistant, or if it is the doctor, whoever it might be, it's good to have that supporting tool to just be able to reiterate everything.
Yeah. And if we've got another minute or two, what I'd like to do is show you how jaw repositioning can make or break a case. So you had brought it up earlier. We want to use this to know who we can't help. And so if I go through different vertical dimensions and they all look the same and none of them improve. So here's the 1 in the 3-2-1. So average airway is about 3, collapse below 2 is a problem. But wherever their minimum was, if I can improve it by 1 square centimeter with just jaw repositioning, the success level of those cases, in my experience, is 90%.
Wow.
If I can't get 1 square centimeter improvement over where they were, it's a more difficult case. It's going to take more work and probably, in my practice, would lead to a higher fee. So not every case gets treated the same. Some people it's a slam dunk. Boom, that's your position. Are you going to wear it? Okay, let's go. And then you deliver it and you're done. That's easy. Like, you don't need to charge a fortune for that.
Right.
But some of them you look at, it's like, I don't even know if this is going to work for you. But they're begging you. Like, I just can't do that mask. I'm not going to do it. And like, I want to live to, be able to play with my kids and my grandkids. And, my parents died young. I don't want to die young. those are the conversations that take place in a sleep practice. And until you're, got that patient asking for the benefits, whatever solution you're going to offer them is going to fall on deaf ears, because they don't think they need it. Mm-hmm. So I want to do 2 measurements. I'm going to do 2 more collapses in different positions. The first one I'm going to do is kind of what like a standard George gauge measurement would do. So it's just a 6 millimeter vertical. This is a little jig called airway metrics. I'm going to set it on my front teeth to hold me open 6 millimeters in between my front teeth. Okay. It gave me a star there because that was the best one we've done so far, which was the only one. Now I'm going to go to 8.
Okay.
And this is still end to end. Goodness.
Well, the minimum went up to 4.3.
Yeah, so that's how much 1 or 2 centimeters or millimeters can make an airway. So wow. No protrusion, end to end in the anterior, 6 versus 8. So let's look at it. Here, the blue line is 6 millimeters end to end. The yellow line is 8. It's 126% improvement. My minimum went from 1.9 when I was at 6 to 4.3, which is far above average of 3.2 for a male.
Right.
And then if we compare this to the collapse, so if we didn't have anything, if you choose to sleep with nothing in your mouth and you have events where you're choking or suffocating, which is the layman's terms for apnea and hypopnea, collapse versus an oral appliance made at 8 millimeters of vertical end to end is 152.9% improvement.
Wow.
An overall volume improvement of 129%. And wow is my favorite word. The spike that we see over here was the increase in verticals. So as the roof of the mouth got higher. Now we have to be cognizant of lip patency. So if we make a device that has a lot of anterior vertical, but we start them mouth breathing, now we've got another issue that we need to resolve. So there's thinner materials now. We also have to be aware that there's no active undiagnosed TM problems, because that will make sleep very erratic. So always triage pain first. Decompressing jaws doesn't take very long to do. And for those patients, you don't want to activate muscles that are going to be angry, because the muscles will always win. But in a patient that's asymptomatic and doesn't have an issue, sometimes a little bit more vertical makes all the difference. Now, sometimes it doesn't, but isn't that valuable information that you want to know before you take an impression, before you take $1 from that patient? If you want to save yourself time and frustration, start down the track of these are custom-made oral appliances that are just for you early in that conversation. And then, like, if you're guessing at this, which is what we call the GG, the George gauge or guessing gauge, you're going to have good results half the time, but you're never going to know when it's going to happen. And then you're going to see them in a month and you're going to jack their jaw forward. And then you're going to see them in a month and ask them if they're still snoring. And some of these patients, if they're mild, they really don't have subjective complaints that might dramatically improve. I was just listening to a sleep physician last week give a talk, and he says, if they're mild, I wouldn't even retest them unless they've gained weight. Because it's not going to show you anything. But on a moderate, as we get into an AHI that's over 15, now we need to do whatever we're going to do and retest it. And he was advocating oral appliance for no matter what severity of disease there was, mild, moderate, severe. In this day and age, it's so difficult to get a CPAP machine, and it's so prolonged to get into a PSG, an in-lab sleep study, that he's advocating. I think, anytime a dentist has identified this, they should go forward with an oral appliance, retest if they're moderate or severe. And if it's being managed, you're done. And if they're not, then, you at least got something in the interim between when the problem was discovered and when it's maybe going to end up properly being managed down the road with what they need.
Yeah.
I was always the opposite. It was like, well, I want all my patients to go try, fail, and hate CPAP and then end up in my practice because it'll make me more friendly with the physicians. They'll know I'm not trying to take all the business.
Right.
I'm not trying to do herodontics. And so I think it gives credibility. Now, the reporting that comes out of these reports is phenomenal as well. And we just, export it and put it into our dental records. And when we send these letters, that's how we talk to physicians, and we have graphs and quantified data. It's not just a subjective improvement. Now it's objective. And then, then you're doing it in their SOAP format. This was the assessment, this was the plan, and this was the progress that we made. And now I'm kicking the patient back to you because, and honestly, dentists don't manage OSA. That's the physician's job. But we have a dental solution sometimes for a medical problem. And medical insurance does pay for this. They do pay for the testing. Now, all policies, pay differently, just like dental insurance. Just because we have a code doesn't mean you're going to get reimbursed, but do it smart and, collect from the patient and bill the insurance. And if the insurance pays, they've got a credit or a refund, but don't do it for free. That was another mistake I made. I was taught by people that just said, you charge for the device, everything else is included. That's wrong. Like, you charge for your time, you charge for your knowledge, your exam, your testing. Once you've got a diagnosis, you've got some billable stuff going on there. And so that's what we teach offices to do all across.
No, Dr. Harrison, if there's somebody listening, a hygienist, a doctor, whoever, somebody out there that wants to learn more about EchoVision, wants to get in touch with you, how can they do so?
Well, I'm going to give you my cell phone and my email. So text message works great for me. Email is very good too. If you want to just see where there's courses being offered, you can go to sleepgs.com. So sleepgroupsolutions.com will also get you there. It's just a lot more things to type, but sleepgs.com, and then click on seminars. We've got an online seminar for those that don't want to get together in live meetings, or if there's not one in your area anytime soon. And we've just revamped our live 2-day seminar. So it's a 16-hour CE course that we take offices through. How do you get started? It really starts before you even get to class. We just recorded Sleep 101. It was myself and our director of education, Rebecca Leahy, who's just a hoot to get to speak with. And it's about 3 hours of pre-course material that these offices need to go through in advance of coming to the live seminar. This sets them up for walking in, being prepared to think about their practice, their patients. We give them a downloadable PDF form of who are the patients that are already sitting in your practice, because they're there. Right. And then we can walk through the numbers and we can come up with the action plan and think about what's this going to look like in my practice? What do I want to do my first year? What do I want to do by my 5th year? Do I want to be a multi-million-dollar top tier dental sleep medicine practice? Do I want to exit my dental career and become, a sleep dentist? Do I want to prolong the years? Maybe I'm just, fed up with drilling and filling teeth or making, beautiful smiles. Right. Let's offer more to our patients and really deliver them the care that they need and deserve, and give them our best. Absolutely.
Because at the end of the day, that's all that matters. And I'm excited. Have some kind, like, if there's any patients that are listening in on this episode, is there any kind of directory to see if there's any providers in their area that have this technology in their office?
I just saw the counter counting down here. So
I know we're going to be wrapping up in a couple minutes.
The easiest way to find a provider in your area is talk to the representative from Sleep Group Solutions in your area.
So they can still contact Sleep.
They can call Sleep Group Solutions. Our client care department can tell them if there's someone in the area or not. But really just reaching out to the account representative and establishing that relationship will put you in the loop. Like, we send out so much stuff of value to people, articles that we come across. We really just want to educate. Sleep Group Solutions started as an education company. We educate first, and then we implement after.
Awesome. Well, thank you so much, Dr. Harrison, for coming on and chatting with us and showing us the EchoVision system. Truly phenomenal. And yeah, thanks again for coming on. We'll have to have you on again. Maybe once you have your repeat, where are you going to have your repeat sleep study to see how things have been since you've gone through your journey? Maybe we can have you back on to talk about that. That would be really cool. So yeah, enjoy your day. And thanks again for your time. We appreciate you.
My pleasure. Have a good day.